to to offer patients the options for ablative therapy when appropriate. So I want to go through just an overview of some prostate cancer treatments, which I think everyone here is going to be well familiar with. So I'll go through those things quickly, but really want to talk more about TULSA. So let's go to the next slides. So this group is well familiar with this, so I don't want to belabor the point. Everyone knows where the prostate is and what it does. It is, it's the most common site of cancer in a man is prostate cancer. So it's a very common problem. Next slide. And we know that approximately 1 in 8 American men will be diagnosed with prostate cancer during their lifetime. And we've always heard that men, don't die of prostate cancer, but in fact, some men do die of prostate cancer. There's estimated 290,000 new cases this year in the United States, but there's over 3 million men currently living with prostate cancer. And approximately every 15 minutes, an American dies of prostate cancer. So there are some cancers that are aggressive. And as this group well knows, our challenge as specialists in this disease is to help to understand who's got an aggressive cancer that needs treatment and who has those types of cancers that we can simply and safely monitor and watch. Next slide. We know that there's a lot of risk factors to this. Obviously, age, the older a man gets, the greater the chances that he'll be diagnosed or will have prostate cancer. Certainly, there's family history. If dad has prostate cancer, if a brother and uncle has it, a first-degree male relative, we know we're at higher risk. There's certain genetic and racial factors, particularly African-American men. Diet and lifestyle likely do play a role. And I've seen clinically in my practice over the years, and certainly I've practiced in areas of, heavy military retirees along the Southeast coast. I've absolutely seen, a greater group of aviators pilots and commercial pilots, military pilots, folks exposed to avionics, high altitudes. I've seen a lot of prostate cancer in this group. So I think the program you talked about is critically important to try and quantitate that and define those risks. Next slide. We all know that the PSA test was the first test used. Certainly it has limitations to it. The higher the PSA gets, the more suspicious we'll be for prostate cancer. But a PSA certainly is not enough to establish a diagnosis. The current state of the art today really is the prostate MRI. The MRI is really been the game changer over the last 10 years, and it really does help to stratify or define risk. And I use it in my practice to help decide who needs a biopsy, and if a biopsy is necessary. If there's an area that's seen on the MRI, that MRI image, that image of the tumor is going to be used to guide a biopsy. And most urologists today have access to something called fusion technology, which allows us to register, overlay the MRI image to an ultrasound and target the suspicious area and make sure that the biopsy is accurate. So, I'm sure you've heard a lot about this, but the current state of the art really is, using MRI is one of the basics in diagnostics. Next slide. So once we establish the diagnosis of a prostate cancer, it's important to think about how a man's going to be treated. And one of the treatments really is active surveillance. 10 years ago, it was rarely used in the United States. Today, thanks to the efforts of the American Urologic Association, as well as really, this has made it front and center into guidelines. Men who clearly have a small amount of low-grade, low-risk prostate cancer are going to be excellent candidates for active surveillance. And that means closely monitoring the cancer. It means periodic PSA tests. It means that periodic we'll use MRI, periodic biopsies, but a significant number of men will avoid definitive therapy. And certainly the older a man is, the more likely they are to avoid therapy. What makes active surveillance an important option is that there's now a lot of data telling us that there's no higher chance of dying in men who have surveillance compared to any other treatment. So for men who really have this slow-growing, low-grade cancer, it really is an ideal an opportunity for treatment. Certainly, radiation has been popular, and over the last 20 years, there's been a lot of advancements in radiation therapy. And different technologies can, as you've heard from different presenters, can treat in as few as 5 days. That's called hypofractionated therapy. CyberKnife would be an example of that, or standard beam type radiation, such as IMRT. And certainly you've heard about different types of radiation, including proton therapy. There's no treatment we have without side effects, and certainly radiation can cause sexual problems, can affect urinary and bowel function, but it is one of the mainstays of treatment today. Prostatectomy really goes back, as urologists, that's how we've defined how we've treated prostate cancer, literally for over 100 years now. In fact, the first description of radical prostatectomy go back to the 1900s, early 1900s. But that's an operation to totally remove the prostate and the seminal vesicle, and in many cases, the lymph nodes. Certainly in the last 10 to 15 years, that technology's gotten a lot less invasive using robotic technique. And so there's been a lot of improvements in how to do a prostatectomy. I think the newest frontier, though, is a category called ablation. Ablation means putting energy, putting treatment, putting targeted energy into the prostate without cutting the prostate out and without using radiation energy. And examples of that would be freezing or cryotherapy, which goes back now in clinical use in the United States well over 20 years, high intensity focused ultrasound, laser can be used for ablation, and now TULSA-Pro, which is transurethral ultrasound. Next slide. So we talked a little bit about surveillance, but surveillance's benefits obviously is that it really avoids the major side effects that definitive therapy such as surgery and radiation would carry. Some men are uncomfortable with surveillance. I think it's our job as urologists to help men understand if they really do have non-dangerous, low-grade cancer, that it's a very safe way to treat them. But a lot of men, especially if they're diagnosed at a young age, will eventually come to some type of treatment. The key is surveillance isn't ignoring the cancer, it is carefully monitoring it. Next slide. The mainstay, of course, is a radical prostatectomy. Again, that's front and center in our guidelines, but that's the surgical removal of the prostate. The advantage is that in higher grade cancers, we have the ability to remove the lymph nodes to get what's called accurate staging, meaning defining where the cancer is it in the lymph nodes or not. And that option has been around for many years and has certainly stood the test of time. However, even despite our robotic techniques, there's very definite risks of erectile dysfunction, and that certainly increases the older you are. There certainly is a chance of incomplete urinary continence recovery. Many men will have leakage early on, and many of those men will have complete recovery, but there's still about 10 to 15% of men who long-term will have some incomplete urinary control, especially when they're physically active, when they're exercising, when they're bending, lifting, moving. And there have been some change in bowel function, although bowel incontinence or leakage is really quite rare with prostatectomy. Next slide. Radiation, again, uses radiation energy aimed from either outside of the body or placed with different types of implants into the body. Different types of radiation you've heard about: IMRT, SBRT or stereotactic radiation, CyberKnife, proton. Brachytherapy refers to placing radioactive pellets into the prostate. Its benefits that it really is minimally invasive in the sense that there's no major surgery involved. It is incision-free, obviously. And certainly the technology, like everything else, has greatly improved over the years. But every radiation modality does require multiple treatments, anywhere from 5 to 45 treatments. And in many cases, especially if there's higher grade cancer, androgen deprivation or hormone therapy is always going to be used. And again, that's part of our guidelines. But radiation is certainly not without its risks. There certainly is a chance of causing a sunburn effect onto the rectum and causing some urgency and frequency of bowel movements. There can be bleeding from the rectum. Some of the rectal bleeding has been minimized in recent years with technology in place, a spacer gel under the prostate. You may have heard about that. It makes the radiation a bit safer for the rectum. Certainly, though, erectile dysfunction is a part of radiation therapy. Early on, it's not as bad, but as the years go by, the ED certainly does progress. Next slide. Focal therapy is more of a generic term. So focal therapy means that we're going to treat a portion of the prostate. The goal of focal therapy is to place energy or ablate an area of tumor within the prostate. Now, that's all depends upon having good diagnostics. We know where the cancer is because of good quality MRI, good quality biopsy, can see where the tumor is, and it occupies a discrete, very obvious region of the prostate. Then focal therapy can be an option. Focal therapy means using some type of image guidance to place energy onto the tumor area with a safety margin. There's different tools to do that. You can freeze that area. High intensity focused ultrasound can be used, laser. And of course, the topic of today's talk, which will be TULSA, can be used to treat focally as well. This is really a very non or minimally invasive option. It's repeatable if necessary. It doesn't limit having radiation or even potentially surgery down the road if that was ever necessary. But the risk of focal therapy is that the entire prostate's not being treated, and potentially there's untreated areas can harbor undiagnosed prostate cancer cells. Or it's also important to note that the healthy tissue as the years go by can develop prostate cancer. Really, it's really a trade-off. Men who have focal therapy, if we've got good diagnostics, we have good certainty about where the tumor is, we can see it well, targeting that area with ice, ultrasound, laser, can really produce a very nice balance between treatment and minimal side effects and really preserving quality of life. Next slide. So HIFU is one of the modalities that's been used. This was approved in the United States for ablation. This was the first ultrasound ablative technology approved by the FDA. It was approved specifically for tissue ablation, prostate ablation, not specifically for cancer, but for ablation. And it's focused ultrasound energy, so it's very non-invasive. The sound energy is placed from a probe in the rectum. The sound energy is focused into a region of the prostate where they're aimed. And the concept's similar to taking a magnifying glass and focusing light rays to a pinpoint. Well, sound waves can be focused to the same area. And using MRI image guidance, MRI fusion guidance, we can treat focally and at times can ablate or destroy even the entire prostate. This is ideal for tumors that are closer to the rectum or the bottom half or the posterior part of the prostate. Tumors that are on the top part of the prostate, the sound waves don't reach them very well. So that's not an appropriate technology. So really, like any other technique, there's a place for HIFU as one of the ablation tools, but it was the predicate or the first ultrasound ablative technique that was approved by the FDA, and that was now back in 2015. I personally have 17 or 18 years now experience with this technology, working with it in the development phases long before FDA approval, and have got over 3,000 case experience with this. So in the right patients, it's a very effective and very safe procedure with minimal side effects. But again, patient selection is going to be very important. Next slide. Cryotherapy is sort of the granddaddy of our ablation techniques, described back in the 1960s, and then sort of revived in the 1990s with newer technology, creating ice. Instead of using nitrogen, we now use an argon gas technique, but the ice is very controllable. I would say the newest advancement in cryotherapy is the ability to use MRI fusion. And so if I'm doing a focal cryotherapy, I'm going to use MRI images and use a fusion technology to see where the area is and control the ice and treat that region of tumor. But it's a minimally invasive approach. It's got a short recovery. A catheter is always required for at least for a few days. The needles have to be placed in just the right orientation. And now there's software to help with that. There's also software that allows for the MRI guidance, which helps with needle placement. This is something that not a lot of urologists do today, but there's a group of us around the country who have a lot of experience with this. When the whole prostate or the entire prostate is frozen, there's a high risk of erectile dysfunction with cryotherapy, although there's not a high risk of urinary leakage. So some of our older men who have significant ED already, this is a nice approach. If the whole prostate's treated, if they've got a focal lesion, especially in the top part of the anterior prostate, it's an ideal way because it's easy to place a needle into the top part of the prostate to freeze a region. That's a place where, for example, HIFU would not work very well. Next slide. So TULSA is really what we wanted to overview a little bit today. So TULSA stands for transurethral ultrasound ablation. I'm going to review with you some of the technology itself, some of its risk benefits, go through some of the data from the FDA clinical trials, and I'll share with you who some of the good candidates may be for that. Next slide. So TULSA is the newest really ablation technique to come along in the last few years. It was FDA approved in August of 2020 for prostate ablation. It was approved based on the predicate device being the HIFU technology. But what's really different about this is that, as you'll see, this is very precise and it's performed inside of an MRI machine. So this is a customizable procedure where a portion, a half, a quarter, or the entire prostate can be treated. So it's very customizable. This is an outpatient procedure performed under anesthesia. And the clinical trials have demonstrated, and it's been my experience as well, that there's really been no damage to the rectum, and the risk of urinary leakage has been extremely low. There is certainly some risk of erectile dysfunction with every procedure, but the TULSA patients, as I'll show you some of the data, have done very well with the maintaining erectile function. One of the biggest risks of TULSA is that there will be urinary retention for a period of 10 to 14 days, and our patient's going to require a catheter for a period of time until that prostate swelling reverses itself and prostate begins to heal. Next slide. So the technology is really very space age, very high tech. There's a device placed into the penis. Now you're asleep, so every guy cringes when I say that. But there's a transducer device that delivers the energy placed through the urethra, through the urethral channel into the bladder, and MRI images are obtained of the prostate. The prostate is outlined, so the boundaries of the prostate are seen, and this transducer will rotate 360 degrees and deliver rays of slow, continuous ultrasound heating from the center of the prostate outward, out to that capsule, and the computer controls this. So the boundary where the prostate is set to achieve a temperature of 58 degrees centigrade, and then the energy shuts off. So it's a very precise way to treat a volume of the prostate, a region of the prostate, with a slow, continuous ultrasound energy that creates heat. And you can see the animation there. That color map you see, the yellow and red, is temperature. So yellow and red is hot. The cartoon itself, or the diagram, will show that the ultrasound element itself that has 10 distinct elements or ultrasound elements that deliver the energy, and they can be controlled individually. There's also a device in the rectum that protects the rectum and keeps it cool. So let's go to the pivotal study. Next slide. The FDA pivotal study, what's called the TACT trial, TULSA Ablation Clinical Trial. This was published in the Journal of Urology in March of 2021. And this was the study that was submitted to the FDA, which ultimately did lead to the FDA granting an ablation label to this technology. 115 men were studied from 45 to 80 years old. They were throughout 5 countries, but most were in the United States. 1/3 of the patients had Gleason grade 6. 2/3 of the patients had Gleason grade 7, or what we call grade group 2 cancer. So 2/3 of the patients were intermediate risk. They all had biopsy documented cancer. Most of the patients had right and left-sided cancer, and most had at least 5 or more cores positive. You can see on the map some of the clinical sites in the United States, including Hopkins, UCLA, Southwestern, Indiana, Vanderbilt, Chicago, Yale. The technique was not focal. This was a whole gland ablation trial. So the entire prostate had to be treated in this trial. The endpoints at 1 year were to look at PSA reduction and to see what the adverse endpoints were, what side effects were there. As a secondary endpoint, they looked at how small did the prostate get? What was the volume reduction? What did the prostate biopsy at 1 year show? Every patient had to have a biopsy as part of this protocol. An MRI was done at 1 year to look at the ablation volume, and then surveys were used to look at urinary and sexual function. The trial was reported out initially after a minimum of 1 year follow-up, but it's ongoing, and data is still accruing in terms of long-term outcomes and functional outcomes. Next. So what was seen here, the PSA reduction was pretty significant. There was a very significant reduction in PSA. The median, there's a 96% PSA reduction was the median level of reduction to a nadir level of 0.28. 86% of men sustained that degree of reduction. The prostate volume went really a tenth of the size. It went in general from 37 cc's to 3 cc's. So it was a 91% volume reduction in the prostate. So although this wasn't part of the trial, you can imagine men who have an enlarged prostate or significant BPH may well be treated with this as well. That wasn't part of this trial, but the prostate gets very small. At 1 year, the biopsy was negative for grade group 2 in 80% of men. That is Gleason grade 3 + 4 = 7, or grade group 2. 80% of men were negative with that criteria. 14% of men had only very low volume grade group 1, or Gleason 6. In other words, they had cancer that could be surveyed or watched. Additional cancer treatment was required in 13% of men by 3 years. So a secondary treatment of some type was required, but in 13% at 3 years and 16% at 4 years. It was a very safe procedure, with only 8% having any sort of serious adverse events, but they all were resolved. There were no long-term events and no injuries to the rectum. In terms of urinary continence, if we look at the men who were socially continent, that is, they did not have any interference with their quality of life, they did not isolate themselves, they can go to the gym, they can play golf, they can do everyday activities, 99% of men achieved social continence really by the 2-year mark. In terms of totally pad-free continence, 94% of men were completely pad-free all the time. No pad, no leak ever. My experience, especially with subtotal or focal procedures, when the prostate's treated partially, over 100 cases now, I have had no patients with pads beyond the 3-month area. So when the focal treatments, as you might imagine, there's less energy, less treatment, and we might see some better outcomes there. Functional erections. Functional erections were recovered basically in 75% of men up to their pre-treatment level. Now, in the first year, there was some significant decrease in function, but by 1 year, 3/4 of the men had recovered functional ability. Next slide. So what's the procedure like? This is an outpatient procedure. It's done in the MRI suite under general anesthesia in almost every case. There will be some medications, typically some antibiotics for a couple of days. There'll be a drug like Flomax, tamsulosin, to help men recover urinary function. The follow-up is very important, though. With any ablative procedure, especially if it's focal, we're going to follow those men extremely carefully. PSAs on a regular basis, MRI imaging, and when clinically necessary, certainly prostate biopsy. Catheter removal, generally in my experience, for the whole prostate can be 10 to 14 days. A focal treatment treating the region might only be 5 or 6 days. Recovery is very quick, though, as you might imagine, because there's no incisions, rapid return to work. Men are usually back to the baseline urinary function within a couple of weeks, and they can return to work very quickly. Next slide. Patients obviously have accepted this as an alternative, and some of our biggest advocates have been some of our patients. But I would say that like anything else, we've got the urologist has got to be able to select patients properly. There's no one treatment that's perfect. There's no one treatment that's for everybody. We got to be very smart about that and select patients correctly. Next. Who's a candidate? You have to be able to have an MRI, obviously. If you have a metallic implant, a penile implant, if you've got an ear, a cochlear ear implant, a pacemaker, those patients are not going to be candidates for being in the MRI suite. Patients have to be safe enough for general anesthesia. And here's the big one. There can't be any significant amount of stones or calcium deposit in the prostate. Stones and calcium deposits will block the sound waves and will render parts of the prostate non-treatable with TULSA. So the urologist has got to be able to screen a patient. Generally, I want to have them get a CAT scan and look on a CT scan or an ultrasound to make sure we don't see any stones that can block the sound waves. Next slide. There's a number of TULSA centers around the United States, certainly here in Sarasota. At our center, we've got an active program, and as Abby mentioned, there'll be a VA center coming on board in Cincinnati, which is exciting. Going to the Profound's website, connect them, they can certainly direct interested people to where there's active sites. But I think this is really all about, having options for our guys. There is no one perfect treatment that's going to fit every patient. Every patient's going to have different preferences. I look at my job as a urologist is to make the proper diagnosis, characterize the cancer, understanding what type of cancer, how aggressive it is, and then give the men a list of options for which they're candidates. Certainly, we've got our base everyday guidelines approved everyday treatments, and they're there because they're readily available. They've stood the test of time. But these new technologies are exciting because they give men options, and men who are proper candidates for that. That gives us another way to look at their prostate cancer and possibly achieve a better balance between treatment and quality of life. So I think that's the end of my formal comments, and I'm certainly happy to entertain any type of questions.
Doctor, thanks very much. We'll open it up to the floor. I mean, if you've got, this is the time now to ask any questions. I see a lot of friends and supporters on here, guys that are interested. So I'll open it up. Anybody has got any questions? Is there, Doctor, you know if there's anybody on here that's actually been through the procedure? Joe, if you didn't go through this, anybody go through this procedure? And I don't think so, but we need to recruit a vet patient to get him on here to be able to talk about these. Ask him from the patient's perspective how it goes, and what are the considerations and things like that. How long did you say is the recovery, like post treatment?
Well, the biggest part of recovery is a catheter, a Foley catheter, and it's going to be anywhere from a week to 2 weeks. Okay. And that's the part guys don't want to hear, but it's part of a lot of the things that we do, unfortunately. But yeah, once the catheter is out, though, the recovery is very quick. Men are back to their full activity within a couple of days of that catheter being removed.
That's great. Go ahead.
Hi, my name is Keith Menz. I'm actually not far from you. I'm down in Naples, Florida. Where are you located in Sarasota?
We're up in the Lakewood Ranch area, a place called Center Point, right on University by UTC.
Okay, by UTC. Okay, great. And two, Mike, I guess more directed to you. Can this procedure be a part of community care network?
The answer is I don't believe so, not at the moment. I think it is from a reimbursement perspective, and Abby, you can tell us from the company's perspective. And I don't know, Dr. Scionti, are you guys seeing Medicare reimbursements yet, or how are the payers treating this?
Not yet for TULSA. I think it's going to, if we look at its predecessor, which was HIFU, it took several years to get a full CPT code, and now we are seeing Medicare reimbursement for HIFU, and in the VA system, and it's not universal, but we've been able to work with some of the VAs around the country to get that into community care. So it's a process, and I think Tulsa and Abby can comment a little more on where they are with the CPT code, but I think that's the next major step. Once an AMA level 1 CPT code comes out, I think that makes the whole process a lot easier.
Well, I think, and Abby, I'll let you answer in a second, but I think once we get once it's installed and being used in a VA, you're going to get some pretty instant, they're going to have a hard time not using it in community care if they're using it inside the VA. So Keith, and I think that I don't know, I'll speak for Profound, but I think that they're counting on that VA experience to help them with the number of positive cases and outcomes that the FDA wants to see, or the CMS wants to see for a CPT code.
Yeah, agreed. Thanks, Mike. And thank you, Dr. Scionti. Interestingly enough, we're in the perfect spot as we roll into AUA, because we have submitted, and it is public, for our Cat 1 CPT code. We should know in a few weeks in terms of approval. And if we do get approved, then that code will go into effect in January of 2025. So right now, our current hospitals and academic centers are treating Medicare patients, and they're using our C code, and that C code, C9734, is getting reimbursed a little bit over $13,000, but hopefully our Cat 1 code application gets submitted and reviewed with a higher reimbursement. So we're very hopeful for some positive news coming soon.
Yeah, so one of the problems that we have with these technologies is that there's a pathway to reimbursement, which can be slow. And sometimes if you're not in the field, no one understands why it takes that long, but there's a process that has to be followed. But if you look at the aggregate cost to the system, to the healthcare system, to deliver these treatments, it's certainly significantly less than a radiation course of therapy, and certainly even less than a robotic prostatectomy. So in the right patients, these types of techniques, and TULSA certainly fits in with that, are going to offer the system, the healthcare system, some cost savings. And if you factor in some of the intangibles, such as quality of life, lost productivity and things like that, then it begins to even make more sense. But this is the arguments that we make on a regular basis with our insurers, and the arguments that we make with CMS through the AUA, through industry, and that's a process that we work on, I think, continuously.
Other questions? I've got a couple of anybody else. Other questions, Joe?
Yeah, Mike, this is Dave Crawford. Can I ask a couple questions?
Yes, of course, Dave. Yeah, nice to see you, Dr. Crawford.
Great. That was a great presentation, one of the best I've heard, and I've heard a lot over the years. Well balanced, and you covered everything. So
Thanks,
congratulations. Couple of things. That first of all, I think you showed that you need more one quiver in your, one arrow in your quiver when you're going after targeted focal therapy and things like that. And there are different utilizations for HIFU, cryo, lasers, and now TULSA. I actually had the opportunity to be trained on TULSA in Nashville a number of years ago. I think it's a great technique. We're hoping to get one in San Diego. The issue is tying up an MRI machine, as you well know. The other thing that you talked about is active surveillance. And we're proud because we find a lot of people for active surveillance. We don't want to find people for active surveillance. We want to find people that need men that need to be treated. Right. And so we have ways to do that. And I'm hopeful that in the VA protocol, they have ways to sift out who gets biopsied and who does not. I really appreciate the work you're doing, Mike, and the stuff with the pilots. We know that guy, when I came to Colorado in the 80s, 86, there were a lot of airline pilots who had prostate cancer, and so did the people on the ground crew, interestingly. So we didn't know why, if it was aromatic amines or whatever. But you also have to be careful it's a group of people that are subjective to to screening, and there may be some bias that goes into it for that reason. As far as targeted focal therapy, I use the word targeted, not focal. You want to know the target. And as Dr. Scionti very nicely pointed out, things near the rectum, maybe HIFU, TULSA, larger lesions, cryo, and there's different ways to do it. I think TULSA is a great treatment and to treat the whole prostate. Your study was excellent, and there's no other treatment that can be done that quickly, gets PSA down and treats the whole prostate. So it's an uphill battle, as you well know, to integrate it and keep it moving. But I think you got a good technique, and there's no reason why it shouldn't move forward.
That's awesome. If everybody doesn't know, Dr. Crawford is just a couple of years of experience in prostates and in urology, and we're huge supporters of his with the work going on with Life on ADT and some of the other things, and just anything to do with raising awareness around guys getting screened earlier, and understanding really what a prostate is, how to spell it, and getting it taken care of. Quick question, Dr. Scionti, are you treating like BPH or anything else like that? And what's the largest size of prostate that you guys are allowed to treat, or and any other conditions that come along with this wonderful organ that we've got?
That's a good question. The clinical trial didn't really address BPH, as I said, but if you think about this, because the energy comes from the center on out, that central tissue, what we call that transition zone, is closest to the heat, it's closest to the energy, and so it gets very effectively treated. And you saw the significant shrinkage of the prostate. You have 90% volume reduction. So yeah, I think BPH is an area that I think needs a lot more study. I've had a half a dozen patients now on that first 100 who were specifically only for BPH, and these were men who, we don't have any great treatments for these large 150 cc prostates. They're beyond what most people want to do a standard TURP or a laser for. There's a lot of minimally invasive techniques which don't work that well in large prostates. Certainly, holmium laser enucleation is a very effective way, but there's not a lot of skills in that. Not a lot of urologists will offer that. So, and it's more invasive. So, I've treated patients. The gland has been up to 150 cc's, but when you drop the transition zone, that central area, it's a lot smaller. So what limits TULSA is not so much the gland volume, it's the distance the sound wave can go. That sound wave can go 30 millimeters, 3 centimeters from the center, the urethra, out to wherever you draw the boundary. So that encompasses a lot of really big prostates if you're treating BPH. So that's an area that I think is going to get a lot more study, because this is a really nice way for these really large glands. And we don't have a good minimally invasive way to treat very large prostates.
Okay. What are you, I guess, how far up on the chain of Gleason scores are you allowed to treat? I mean, obviously it's all supposed to be localized, and where are you seeing the limits? And are you still doing, is it always a whole gland treatment, or are you looking at doing more precise with all this precision imaging coming along? Are you will anybody start doing just parts of gland and just, tissues or cancerous tissues in the gland?
So 2 questions. The Gleason score is a good question. So if we go by, published clinical outcomes, there's really no published experience with these very high grade tumors. So, Gleason grade group 4 or 8 or 9, there's really no experience with that. And I'd be very reluctant to use, the technique for someone with very high grade cancer.
Yeah.
The studies really focused on the intermediate risk, particularly 3+4. But I think 4+3 as well. If it's in the range, easily we can get energy to. I think that I would treat that. But I get I really have not treated any high grade tumors, and it's simply because not that we can't or not that it wouldn't work, but now we're dealing with a very risky cancer, and we just don't know what the outcomes are. So I think if that's done, if you look at this has to be looked at in a very controlled study. If you're going to ask, does it work for high-grade cancer? We don't know. That's the answer. Now, focal therapy, targeted therapy. I agree with Dr. Crawford. I don't like the word focal because it means you're treating one little tiny spot. Diagnostics have gotten very good today. And men who have a regional tumor, an area well seen by MRI, confirmed by targeted as well as systematic mapping biopsies. I think there's a role there for genomic markers as well. But people who have regional, well-visualized, isolated tumor regions, you can treat beautifully with TULSA like any other technique. And where it's particularly useful is what's called an anterior tumor. Some of these tumors just drape across the top of the prostate, and there's limitations. We can't get there with HIFU. If it's right in the center, it's kind of hard to get the ice to overlap right over the top of the urethra sometimes. TULSA can do a beautiful job with that. So again, targeted approaches, there's a big role, especially anterior lesions.
Yeah. And this maybe is for you and also maybe Dr. Crawford, if he's listening. Do you guys see a study coming on to do just partial gland treatments with this kind of a technology? Or, because I think like Dr. Crawford said, active surveillance, okay, great, you've got this cancer. Why don't you just take it out if you can? And if you can take just a portion of it, why not? Why don't you do it? And is there a study coming along? Or are you guys envisioning one that's going to start to look at this sort of treatment? Because I think, as I understand it, prostate's still the only whole gland treated cancer out there. Is everybody else is just taking biopsies or little pieces of the tumors and that kind of thing.
Well, I'll go ahead and say a couple words. Sorry, when I was speaking before, I was out of breath. I was doing my Peloton, so now it stopped. Yeah, but anyway, exercise is great for prostate cancer, I think. Not that I have it, but anyway, Dr. Scionti's in the sort of the home of focal therapy. Winston Barzell and Gary Onick were there in Southwest Florida and over in the East Coast. And they're really the godfathers of all of this stuff. And basically, Gary's feeling from early on, I'm sure you know this, that he would treat Gleason 8 and 9. And I do that too. A Gleason 8, I think, is more responsive to cryotherapy, HIFU, and probably TULSA than it is to radiation, because you always hook up ADT with it. And so a Gleason 8 doesn't care, if or any different in destruction if you get it down to -40 with cryo and heat and other things. So I think that's part of it. And so I think we don't want to be boxed in with grade group 1 and grade group 2. We need to adventure out, because as you just mentioned, with markers and other things, we're finding smaller, higher grade lesions. We see them all the time. And I think we just, the sort of the reflex is, oh, they should get a radical or they should get radiation and hormones. And I don't think that's true. We've got some people way out. We've been doing focal therapy for almost 15 years now and doing okay. It's all about patient selection. And we're going to get better at it with the PSMA scans that help, markers help, and other things to target what you want to treat. And this TULSA, I think, is a great way. The other thing is, I'd be interested to know in your study, what were the AUA symptom scores of the men if you have them before you started? Because as you well know, the main reason people were biopsied is their PSAs elevated, usually from BPH, and then you find these low-grade cancers. So you have any data on that from the study, what they were and what happened?
Yeah, I don't have the slide up, Dave, but the AUA symptom scores definitely improve. And that's absolutely, and we see that, I mean, in clinically in the practice, it's a marked improvement. Especially when there's significant, BPH and lower urinary tract symptoms. And it's exactly what you would guess, because the transition zone gets a lot of energy.
Right. The other thing is, I wonder, a lot of the things we're using to treat BPH right now are Urolifts and steam and resume and things like that. They don't penetrate the whole transition zone. So I wonder, when you're using TULSA, you're devascularizing a lot of those lateral lobes. And, I would bet that you would get an improvement and get some reduction in symptomatology that you don't have to treat the whole, 5 centimeters out or whatever.
No, I think that's exactly right. If you can get, if these big glands, one of the early patients we treated had 150 cc gland and had been in and out of retention. He was a young guy. Getting out 3 centimeters really was able to get his entire transition zone. And he just had his symptom score literally went down to 2, went from 30 to 2. So, I mean, miserable life,
Wow.
normal function with a strong flow. So it was shocked to see how well it worked. But that was one of our early patients we treated. And so it's, again, I think it's going to be a really important modality for these large glands.
Well, a lot of the people that I see with focal lesions, say in the peripheral zone and lateral, and then they have AUA symptom scores of 20, large transition zone. If I'm using cryo, I'm going to go ahead and treat both sides. Put a probe or 2 up in the transition zone and treat them besides their cancer on the left or right side. You can't do that very well with HIFU and some of the other techniques, but I think you can do it with TULSA pretty easily.
Yeah, and the other thing we didn't talk about here a little bit, if we're treating most of the gland, it's easy to draw the boundaries around the nerve bundles, a bit more medially and stop that energy before it gets near the nerve bundles. When, it's easy to preserve tissue in those posterolateral nerve bundle areas. So again, it's really, really flexible a tool. And, and it's something that urologists can generally learn fairly easily. It's very robotic. And most urologists now are getting experience with looking at MRIs. They know the anatomy, and it's something that I think is going to be a really important tool for us.
That's great. Open up to the floor. I'll encourage any of you other guys have questions, comments. I see a couple of.
You took my question, Mike. I was going to ask about what's the restriction for grade group 3?
Okay.
It seems like to be the next step up.
Well, there isn't a formal restriction. It wasn't formally studied in the study. So I agree with what Dr. Crawford said. I think is right. And if you can get energy, ablative energy on a tumor, the Gleason grade really shouldn't matter. Now, the concern, of course, is there's not a lot of data out there in treating the really high grade ones. Are we, what are we going to? Can we promise that patient we can treat it? Well, no, we don't really know. All right, but theoretically, and I've used cryo this way for 20 years now, freezing high-grade tumors has been very effective. And we know that. We can go back in the cryo literature and we look at data that goes back now, back into the late 90s, publications showing for high-grade, high-risk cancers, really effective cancer control and excellent PSA control. We're not quite there yet with TULSA for high-grade, but theoretically, if the beam can reach, if the energy can reach the target with ablation, the Gleason grade really shouldn't matter if you can reach.
Yeah, I agree. And like you, I've got some people out 15, 20 years that had this their prostate had extensive Gleason 8s and some 9s that we treated, and they're still doing well. The other interesting thing about some of these ablative techniques is what you call the escopal effect, but that I don't know if you've seen this, but you people that you've treated with cryo, I don't know if you've seen it yet with TULSA, it hasn't been around long enough, that you can treat one area of the prostate and many times, not many times, maybe 15% of the time, there'll be involution of the rest of the prostate. So that's got to be some sort of immunological effect. We studied that and showed that some things happen. And I'm not sure you see that with radiation. That's becoming sort of the thing that people are interested in right now for oligometastatic disease and so forth.
That's great. We'll go around the horn one more time. I see thanks. I see a couple of our favorite nursing staff on here. Thanks for your attendance this evening. And I'll remind everybody while we're waiting for another question, Thursday night at AUA, we have our first VPCa sponsored roundtable session, which is the topic is addressing prostate cancer care in the VA. And we're lucky enough to have some of the leading department heads from Hines VA in Chicago. They're going to be in attendance. Some of the head oncology nurse is going to be there. Their clinical trials director is going to be there. So we will be recording that as which is sort of the objective here. And really it's to talk about, we're going to bring up and talk about a number of these things like the standardization of care across the VA as identified by the legislation that came up. We're going to talk about the change of what we think change of guidelines should be based on the DoD study that has been presented. We talk about how to better facilitate the care in the community and what are the downsides that the physicians and the nursing staff are seeing. We know one of them is the retrieval of data from the community back into the VA, because it's remember the VA is trying to provide whole health care, and they're not getting all of the data back from a lot of the clinics. And so you're ended up with a guy that with clinics having to reach out and try to find care from your physicians that have treated these guys. So it's very important that we watch that or make the standards right. So yeah, anything else? I mean, any other questions anybody want to ask? And if not, I think we're pretty well at the end of the evening.
Good session.
Thank you, Joe, and thanks for being here. I appreciate everybody's attendance and your questions. Tom, thanks for showing tonight. Good to see you.
Be seen rather than viewed.
Yeah, and yeah, I appreciate everybody's participation. Abby, what can we do as a group to help Profound and help you get the word out? And where do you need us to focus our attentions in the marketplace?
Mike, thank you so much for asking. I mean, for us, it's still just building our brand, driving education, awareness, and access for the technology. And our ultimate goal is to make this a part of standard of care for men's prostate disease. So we're very excited. Two things: I would love to be able to know where the recording is found so we can share it on all of our social media networks. And then for everybody on the call, Mike has my cell number. He has got my email. So if there is anyone that wants to talk to me or the Profound team about the technology, we are here to pick up the phone, answer your calls, and educate. So thank you so much.
Yeah, that's great. And what I would also add to Abby's request or info is that they're incredibly responsive, Profound is. And so if you have guys or we're going into the VAs and you're having a discussion with either other patients or urologists that are in your VAs, and you want to take some information in and talk about it with them, please send Abby an email. I will make sure that everybody has access to Abby's email, and you guys can request. I'm sure that Profound would be happy to deliver you a FedEx package full of brochures and information about what Profound is all about and what TULSA is all about.
We would love that. And Mike, if you want to actually put my email or info@profoundmedical.com on the link for anyone to watch the recording, we are there for that too.
Okay, yeah, we will, and I'll make sure everybody on here has your contact, your website, and knows how to make a request for materials.
Thanks, Mike. I appreciate you. Thanks, guys. Thanks everybody for joining.
Yeah, thanks everybody. With that, if there's anything else, next month, the 30th of May. So it'll be just before ASCO. And we will be having our next roundtable session as well on the 1st of June, the night before start of ASCO back in Chicago. So we'll see everybody on 30th of May. And thanks for everybody's participation. Dr. Scionti, thank you very much. Great presentation, and really enjoyed learning more about Profound and about the TULSA-Pro procedure.
Gentlemen, thank you.
Yeah, our pleasure.
Thank you, Doctor.
Thanks, Doctor. Ben, great seeing you. Take care, and thanks a lot.
Yes, sir. Always good to see you, Terry.
Yep. Keep your knots up, buddy.
Yeah, we'll see. I'm going to see Mary in couple of days here, so. look
Yeah.
forward to it.